Hi again. We're continuing on with the respiratory system here. In part two, we're going to be examining the pharynx, the larynx, the trachea, the bronchi, the bronchioles, the alveoli, which collectively, those last three make up the lungs. So let's begin. We'll start by talking about the pharynx. The pharynx connects the nasal cavity and oral cavities to the larynx and the esophagus. And it can be broken up into three parts, rather simply, actually. Throughout the pharynx, the wall of the pharynx is heavily muscularized. It is skeletal muscle. You actually do have some control over it. The three regions of the pharynx are the nasopharynx, which corresponds to the region posterior to the nasal cavity, the oropharynx, which corresponds to the region posterior to the oral cavity, and the laryngopharynx, which is inferior to the other two. So the nasopharynx is the most superior, the oropharynx is in the middle, the laryngopharynx is at the bottom. And then you would see underneath that the trachea and the trachea and the esophagus. Notice that there's a separation, and you have to make sure that the food goes into one of those tubes and not into both of those tubes. The nasopharynx, as I said, right here, is posterior to the nasal cavity. It's just underneath the sphenoid bone right here, and right above the soft palate, which is right here. Please note that it is above where food enters the pharynx. So this is strictly an air passageway. And you should be thinking about that when you're considering what type of epithelium it might have. We already know that the cells in this area have pseudostratified ciliated columnar epithelia. That's going to be the same in the nasopharynx. You don't need to have a stratified squamous epithelia in the nasopharynx because in theory, food should not be coming up there. The way this works is when you swallow, the very end of the soft palate right here is this small smooth muscle or tissue called the uvula. This is the uvula right here. Sometimes if someone opens their mouth really wide, you can actually see their uvula at the back of their oral cavity. So this little soft tissue here swings upwards when you swallow. So part of your swallowing activity is for this structure to swing upwards. And by doing so, it prevents food while you swallow from going up into the nasal cavity. It's obviously not perfect. We've all snorted food into our nasal cavity by accident. You know, when you laugh really loud, and sometimes accidentally the food can make it up there. I'm sure many of you have blown milk out your nose when you laugh too hard. Laughing does inhibit the flapping of the uvula. So it's not a perfect system, but you know that if you have had food go up into your nasal cavity, it really hurts because it's not a tissue that's designed to have access to things like food. The nasopharynx is continuous with the nasal cavity. You can see that here. So here's the nasal cavity. You can see the three conchae right there, and you see posterior to it is the nasal cavity. It's a continuous, the nasopharynx. This is a continuous structure, and so it has, as I said, the same mucosal epithelial lining. It has pseudostratified ciliated columnar epithelia with mucus. It continues the movement of mucus into the digestive system. The other thing that's present in the nasopharynx of note is the pharyngotympanic tube, which drains the middle ear cavities and ensures the middle ear pressure is the same as the atmospheric pressure. So if you're finding yourself disoriented or sort of unbalanced, it may be because there's some sort of problem and there's no equilibrium between those two compartments. There are also pharyngeal tonsils that are present here. You'll talk about tonsils in 1260 in quite a bit of detail. We won't really deal with it here, but basically in a simple sense, it helps to destroy pathogens that are coming into your respiratory system through your nasal cavity. Inferior to the nasopharynx is the second subsection of the pharynx, which is the oropharynx. You can see here it's posterior to the oral cavity, and it's actually continuous with the oral cavity via this archway right here. That archway is called the isthmus of the fauces. This is an area where both food and air will pass, right? If you're breathing in here, the air is going to go through here. If you're breathing through your mouth, the air is going to go through here. If you eat, though, the food will also go through here. So now we're not dealing with strictly an air passageway. We're dealing with a passageway that has both air and physical materials in it as well. Because food is now present, or it can be present in this region, the pseudostratified ciliated columnar epithelium of the nasopharynx in the oropharynx then transitions into a stratified squamous epithelium. Remember, the stratified squamous epithelia is always going to be present, or you would expect it to be present, in areas of the body that are subject to sort of physical stresses or physical damage that can handle the friction. There are paired palatine tonsils that are found on the walls of the fauces and provide immune protection against various foodborne pathogens. This works in concert with these lingual tonsils that are associated with the tongue. Inferior to the oropharynx is the laryngopharynx. Here, you can still see that this is a pathway for food. The food will continue down the esophagus, or air. The air will go through here and then get passed down into the larynx, down through the trachea. So because this has also got food present in it, or at least has the capability of having food there, this is also going to be lined with a stratified squamous epithelia. It's found posterior to the epiglottis. Here's the epiglottis right here. And so the laryngopharynx is behind it, and it extends to the larynx. And we'll talk about what the larynx does. This is a very key point of location in your body. It represents the point in which the digestive system and the respiratory system diverge. If you go straight down through here, you go down through the esophagus. If you go forward anteriorly, you're going to go down the larynx. And you've got to make sure that the food doesn't go down the larynx. The food goes down only the esophagus. That's what the epiglottis is going to do, and we'll talk about that in a second when I talk about the larynx. You'll notice from this picture here that the laryngopharynx is continuous with the esophagus right here, not the trachea right here. The act of swallowing temporarily stops airflow. Food is given right of way. So if you're breathing and eating at the same time, which is likely, food will get to go first. You'll actually block your airway off temporarily, and you'll notice this because you're not going to breathe very much when you're eating for that reason. When you talk about the larynx, there's a lot of complexity here. There's 3 pairs of small hyaline cartilage plates that form the lateral and posterior wall of the larynx. There's many different types, arytenoid cartilage and other types of cartilage. I don't really want to dwell on it, but from this figure here, you can see in blue, there's lots and lots of different cartilage types that are present. And these are very important in terms of making vocalizations. And but since we're not talking about that in this course, I just want you to see it and appreciate that it exists, but it's not something that I'm planning on examining you on. The final piece of cartilage in the larynx is the epiglottis, this thing right here. The epiglottis is this heavily elastic cartilage. Remember, it's one of the few examples of elastic cartilage in the body, and it's lined with epithelia. Actually, there's taste buds in it even, in this epithelia, so you can taste a little bit on your epiglottis. So when air is entering the larynx, the inlet here is going to be open. The free edge of the epiglottis up here is pointing superiorly. It's pointing upwards. When swallowing, so if you've got food in your mouth and you swallow, the muscular contractions associated with the swallowing are going to pull this epiglottis down. And in doing so, it's going to cover the entrance to the larynx and in other words, hopefully blocking food from entering into your windpipe. If a mistake happens and something other than air enters, the first thing that will happen is the neurons there are going to sense that, and it's going to trigger a coughing reflex. So that's why sometimes when you're eating and something, we say food goes down the wrong way, you say, well, it causes you to cough. And this is something that you don't have control over. Again, aside from the epiglottis, I don't really want to spend too much time on the larynx, other than, again, just to point you to this is where the vocal folds are found, and this part of the respiratory system is very important for voice generation. You can see all the different types of cartilage there. But the only one that I care about is that epiglottis. Just to prove that this is a very bony cartilaginous structure. This is the cartilaginous framework of the larynx. Again, just a remarkably complex series of cartilaginous plates. It's all hyaline cartilage and bone. This is the posterior view rather than the anterior view, but again, there's not a lot on here that I'm expecting you to know, but it is nonetheless a pretty cool picture. The larynx leads into the trachea, also known as the windpipe. This is a cross-section of it. I want you to get used to the histology here. And you can see the trachea, which is surrounded in hyaline cartilage in blue here, is anterior to the esophagus. And you can see that there's actually a point in which these two tubes kind of interact with one another. And I'll talk about that in a second. What I'd like you to focus on here is the walls of the trachea. So just like when we did blood vessels, we talked about the tunica interna, the tunica media, and the tunica externa. We're going to do the same thing and break down the layers of the tissue in the trachea. This is one of the bigger points of this week's work. So just to start off, we start off right here with the mucosa. The mucosa is, now remember, now that we're in the trachea, the respiratory system, the digestive system have diverged. So now it's just an airway again. We don't need to have stratified squamous epithelia. We go back to the default for the respiratory tract, which is pseudostratified ciliated columnar epithelia with mucus. You can even see the cilia in the picture here. And exactly the same thing as in the nasal cavity and the nasopharynx. The cilia are there to crowd surf the mucus and any associated debris that got filtered out of the air and send it to the digestive system. The difference between the trachea and the nasal cavity is that the cilia in the trachea are beating upwards, because remember, the digestive system is up back at the larynx. You got to go back to the larynx and then down through the esophagus in order to get pooped out. In the nasal cavity, it's above, so the cilia are going to be perpetually beating the mucus down towards the larynx and then the esophagus. Okay, so we have our mucosa, which is consistent of pseudostratified ciliated columnar epithelia with mucus. It has a basement membrane that is rich in elastic fibers, so this is a stretchy, elasticy type tissue. The submucosa is the next layer. The submucosa is connective tissue wrapped around the mucosa and helps produce enormous sheets of mucus. So it has these seromucus glands that are present within it. Surrounding the submucosa, in blue here, is a very, very thick layer of hyaline cartilage. Remember, hyaline cartilage is made up of only collagen and is flexible and highly resistant. We find it sort of like sheets of bone, just a little bit more pliable. The outermost layer, and this is a term you're going to see a lot, not just in 1160 and 12, but also 1260 as well, is the adventitia. The adventitia is the outermost layer of the trachea, as I said. It is almost identical to the tunica externa of the arteries. It's very protective, it's very flexible, it's made out of dense, irregular connective tissue. The other thing I'll point out when we look at this is I'd like you to see this region right here and notice that the point in which the trachea comes into contact with the esophagus, this posterior region of the trachea, if you will, is lacking any of these dense connective tissues or hyaline cartilage. All the hard tissues are absent on the posterior side. This is to accommodate the esophagus. So right now, the esophagus in this picture, there's no food in it. But what would happen to the esophagus if suddenly there was a big bolus of food in the middle here? Well, that's going to stretch the esophagus to make it bigger. And if there was hyaline cartilage filling up this region right here, it would stop the esophagus from being able to get bigger, which would be obviously very bad for your digestive system, and food would get lodged in your esophagus when it fills up. So what you have instead of hyaline cartilage and adventitia in this posterior region of the trachea, what you have instead is this muscle called the trachealis muscle, which can constrict the trachea and hence increase the speed through which air flows through it. So you can actually it's not vasoconstricting because it's not the blood vessels, but you can actually constrict the trachea to speed up the airflow through it. This will also help speed up the release of mucus by contracting in this way. This is histology, so I just wanted to show you what the picture looks like in real life. So again, just to focus here, this would be the lumen of the trachea. Here you can see all the different cilia crowd surfing the mucus on the apical surface of these cells. Here you can see the pseudostratified columnar or ciliated columnar epithelium right over here. That's how you know they're pseudostratified. There is an underlying basement membrane which consists of material called and this is the first time we've used it here, the lamina propria, which is made up of connective tissue, and specifically it's made up of areolar connective tissue. Surrounding the mucosa is the submucosa, so you can see this area right here is the submucosa, and you can see in some cases like here and over here, I don't see another one, that's where the seromucus glands in the submucosa are, and they're going to be producing the mucus that gets sent out into the lumen and then will get crowd surfed onto those cilia. And then finally the last layer here, as you can see over here, these are chondrocytes. And so this lower layer is the hyaline cartilage layer that's associated with that. All right. Now that we're done with the trachea, we can go into the bronchi. We're almost done with the conducting zone now. We're almost about to transition into the respiratory zone. So there's about 23 branches of air passageways in the lungs. Collectively, this is called the respiratory tree. This is where the conducting zone will eventually, as I say, give rise to the respiratory zone and gas exchange can start to take place. The first thing you'll notice is that the trachea divides to form left and right primary bronchi. This is not a symmetrical thing. Notice the right bronchus is shorter and wider than the left bronchus. Each bronchus will then divide further into lobar secondary bronchi. 3 on the left, 1, 2, 3, and 2 on the right. Each one of these lobar bronchi or secondary bronchi supplies a lobe of the lung. So again, you can see there's multiple lobes to each of these lungs, although there's a different number on each side. They then branch into further into other bronchi. So we have segmental bronchi, which are also called tertiary bronchi. They will divide into increasingly smaller bronchi as well, and they will divide even into smaller bronchi as well. Once the tubes, this is the rule, and so you should probably write this down because it's an arbitrary one. Once the tubes are smaller than 1 millimeter in diameter, they now are called bronchioles. The smallest bronchiole, which is less than 0.5 millimeters in diameter, are called the terminal bronchioles. So what I want you to envision when we talk about the bronchi, so we have our trachea. It branches into the primary bronchi, which then branch into the secondary bronchi, which then branch, I should draw the secondary bronchi, which then branch into tertiary bronchi, which then branch even further into smaller bronchi, and then at some point, those bronchi get so small in diameter that they are now called bronchioles. And at the end of the bronchioles, you get your terminal bronchioles. And the terminal bronchioles are what gives rise to... sorry, that was really sloppy. And the terminal bronchioles are what ultimately gives rise to the respiratory zone, where you're actually allowing for gas exchange to take place. So what I want you to notice, or at least take note of, is as you transition from these big tubes like the trachea and the left and the right bronchi into the secondary bronchioles and so on, is that there's going to be progressive changes to the histology that I outlined of the trachea. So first I want to highlight that there are major changes to support structures. The trachea and the bronchi have these cartilage rings that are like C-shaped rings. You saw them on the previous slides when we talked about the trachea. By the time you reach the bronchioles, the cartilage rings have been increasingly replaced by these irregular plates of cartilage rather than these perfect C rings. By the time you actually get to the end of the bronchioles or the bronchi and start getting into the bronchioles, these pieces of cartilage are gone. You no longer have cartilage in the area. The elastic fibers remain, but the cartilage is gone by the time you get to the bronchioles. I also want to note that there's changes or transitions in epithelia type. Remember, the trachea is pseudostratified ciliated columnar epithelium. You'll probably see that in the bronchi as well. But as you start transitioning to the bronchioles, you see a transition from pseudostratified ciliated columnar to to simple columnar, and then to bronchioles, which are simple cuboidal. As these transitions to epithelia are happening, you're going to see a decrease in cilia. You're going to see a decrease in mucus producing cells. Remember, that's problematic because one of the functions of the mucus is an immune function. It's to actually trap microorganisms and then get sent out of the and take it out of the body. So in most of the bacteria and the germs that get into your respiratory tract end up in mucus, and then they get, as I've told you so far, they get crowd surfed by cilia off to the digestive tract. Once you get sort of close to the end of the bronchi and now into the bronchioles and the respiratory zone, and there's much less cilia, much less mucus, the debris is no longer removed by this mucus cilia thing. Instead, it's going to be removed by macrophages. Again, those wandering Roombas that are cleaning up all around our all the tissues of our body. So there's macrophages here as well. The other major change that you're going to see, kind of inverse to the changes to the cartilage that we saw, is that as you go from the trachea to the bronchi to the bronchioles to the alveoli, you're going to see an increase in smooth muscle. The smooth muscle increases the ability of bronchioles to have resistance to air passage under certain circumstances. We'll talk about that in a subsequent lecture when we talk about the regulation of the respiratory system. Now we're into the respiratory zone. The start of the respiratory zone is when the terminal bronchioles branch into respiratory bronchioles within the lung. So here's the terminal bronchioles right here, and then you see they branch off into these respiratory bronchioles. And this is deep within the lung. So protruding, if these are the respiratory bronchioles here, protruding from the respiratory bronchioles are these alveolar sacs. They look like sacs of grapes, right? They are connected to the respiratory bronchioles via alveolar ducts that I'll show you in a second. The alveolar sacs are filled with alveoli. That's the individual grapes. And the primary job of the alveoli is to maximize surface area for gas exchange between the lungs and the blood. So again, note the difference. The alveoli are the grapes. The alveolar sacs are the bunches, the bunches of grapes. Each individual grape is an alveoli. By the time we get to the alveoli, there's been so much branching in the respiratory tract that there are at least 300 million alveoli in the lungs. And here you can see what the tissue looks like. You see that there's a lot of space in that tissue? What's going to be in that space? These are little pockets for air to be in. And these little pockets, these little circles that are pockets of air, are going to interface with blood vessels and allow for exchange to take place. So now I want to focus on how the capillaries interact with the alveoli in the lungs. So again, you can see our alveolar sac, and you notice that the pulmonary capillaries, this network of blood vessels, over the surface of the alveolar sacs, it's almost like they're cobwebs. They just cover the surface of it completely. Collectively, the combination of the capillary and alveoli right here is called the respiratory membrane. And we'll describe this membrane very, very shortly. In the alveoli, there are two types of cells. The first type of cells are called type 1 pneumocytes, or type 1 cells. This is a simple squamous epithelia. It's the primary cell type of the alveoli. It has a very flimsy, small basement membrane. Its job, again, is to maximize gas exchange. These are incredibly, extraordinarily thin cells, and their job, basically, again, is just to maximize surface area for gas exchange. These are the majority of the cells lining the alveoli, the type 1 simple squamous epithelial pneumocytes. The other type of cell that's found in the alveoli is the type 2 pneumocyte, which is a cuboidal epithelium. See how these cells are a little thicker over here, and then the one that's highlighted right there. The purpose of these cells is multifold, but the one that is most relevant to the respiratory system is that it produces a molecule called surfactant. And we'll talk about surfactant in a subsequent lecture, but basically it's a molecule that helps keep the lungs inflated so they don't collapse on themselves. The type 2 pneumocytes also secrete some antimicrobial agents, so think like lysozymes and defensins. The other thing, and I don't want to spend too much time talking about this, type 2 pneumocytes produce a protein on their surface called ACE2, or angiotensin converting enzyme 2. That is actually the protein that the COVID-19 virus binds to in our body. So the reason COVID-19 causes a lower respiratory tract disorder is because it binds to these type 2 pneumocytes, and this is where the infection is initiated. So these are very, very relevant cells right now. And notice again, you can clearly tell the difference between the type 2 and type 1 pneumocytes because the type 2 pneumocytes are much thicker. You'll also notice, I forgot to mention this, like right here, these dark cells, there's one right there, there's one right there, looks like there's one maybe right there as well. Those are macrophages. So these are found crawling along these spaces in the air pockets, and they are going to digest any debris that didn't get filtered out earlier. And when they digest that debris, they're going to walk up back to the bronchi, and then they can get caught up in that mucociliary escalator that will bring them to the esophagus. Some other key features of alveoli. One, they're surrounded by elastic fibers that surround the entire respiratory tree. In other words, they're stretchable. This is very good because the respiratory system, of course, is a pressure-based system. There are open alveolar pores that connect adjacent alveoli and sacs. So this allows the air pressure in the lungs to be equalized and provides alternative routes for airflow in case some of the alveoli get diseased or damaged. So there's never going to be a dead end. Air's never going to get trapped down here. And then finally, as I've mentioned a few times, these alveolar macrophages crawl along the surfaces of the type 1 and type 2 pneumocytes. Alveoli are, as I said, dead ends for microorganisms. So anything that did not get filtered out and does make it into your alveoli will invariably get picked up by the macrophages. They're going to phagocytose the invaders, and then they're going to crawl back to the bronchioles, get swept up by the trachea, through the larynx, through the pharynx, then out through the esophagus, all because they get trapped in the mucus and they get stuck on that mucociliary elevator. We eat something like 2 million alveolar macrophages a day. It's a remarkable story, actually. I know this picture looks very complicated. This is just to highlight the respiratory membrane. Don't overthink it. I just want to show you, again, the interface between the blood and the alveoli. So here you can see 1, 2, 3, 4, 5, 6 alveoli, and see interspersed between them are blood capillaries. And this is where the exchange is going to take place. So please notice that. Notice that the alveoli are filling up with air. You can actually see that there's those alveolar pores that connect neighboring alveoli so that even if one gets decompressed, not everything is going to get decompressed. You can see the type 1 pneumocytes, the flat cells that make up the alveoli. You can see the type 2 cell types over here and over here. You can notice the macrophages, that these purple cells that are crawling around all over the surface. And you can notice again, the capillaries surrounding the alveoli. If you zoom in at the interface of the respiratory membrane, so on this insert in the picture here, you can see that there's 2 membranes in play. So here's the alveolus. So this is where all the oxygen is. Here's a type 1 pneumocyte right here. And then on the opposite side of this, we have red blood cells, and they're swimming around in a blood capillary. What's the wall of the blood capillary? That's the endothelium, right? That's the simple squamous epithelium that's surrounding the blood cells. So what we have here is our respiratory membrane is actually a double membrane. The first membrane is the membrane of the alveolus created by the type 1 pneumocytes, and the second membrane is the endothelium created by the simple squamous epithelia of the tunica interna of the blood vessel. That's your respiratory membrane, that double mechanism. Now, what you have then, therefore, is you want oxygen to go from the alveoli across the alveolar type 1 pneumocyte membrane, across the endothelium, and get into the red blood cells in the capillary. And conversely, you want carbon dioxide to leave the red blood cells, cross the endothelium, cross the alveolar membrane, and reach the alveolus, where then now the carbon dioxide can build up in your lungs and then be expelled out of the body. Okay, that was a pretty long one, so I might not make another one for a couple days, but after completing this mini lecture, you should be able to, first of all, describe the structures and arrangements of the pharynx and the larynx. A major point of this part of the course would be to describe the tissue architecture of the trachea. You will also be asked to do the histological modifications to the lower respiratory tract as you transition from trachea to bronchi to bronchioles to alveoli, namely movement away from cartilage, so the beautiful C-shaped rings of hyaline cartilage that you see in the trachea and the bronchi become more irregular as you move more distally through this structure or this tree, eventually to the point where you have no cartilage. That cartilage seems to be getting replaced by smooth muscle, as I said earlier. There's also additional histological modifications to the epithelium, for example. We go from a pseudostratified ciliated epithelium to ultimately a simple squamous epithelium in the alveoli. And then finally, I'd like you to be able to describe in detail the respiratory zone and talk about the type 1 pneumocytes, the type 2 pneumocytes, the macrophages, the endothelial cells, those components of the respiratory membrane. You should be able to define each of those cell types. Okay, so that's it for now. See you soon.